Okay, are you guys done with the test? Okay, gotta say something.
Yes.
Okay.
Yes, I'm done.
Done.
Okay. Is there anyone still on the test, working on the test?
Karima got on.
I'm sorry.
I just got on.
Okay. Lori?
Yeah.
Okay.
So I haven't even started.
Okay, no problem. Take your time. It should take like 2 to 3 minutes.
But I'm looking for it. So where is it?
You know, on the Showcase app, the yellow sign on the left of your,
Yeah, I got
screen.
that.
The second link, the one with the picture.
Okay.
Okay. Okay. Can you guys please click on the first link, which is the Hematologist-Oncologist? Now, this is a link to the presentation, the Prezi presentation I'm going to be showing. You just click on the link, and I'm going to be moving the presentation. Now I have 2 people joined. 3, 4. Yep. There's still 2 more people who didn't join the Prezi presentation. Okay, Lori, are you done?
Yeah, I can't get back to the presentation. Where is it at?
Lori, we lost you on the call. Okay, now I should start. Who did? Is everybody? Has everybody joined the Prezi presentation? Please say yes.
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 Ren?
Yes.
Vanessa said yes. Omar?
Yes.
Okay. Omar? Omar, can you hear me?
Can you hear me now?
Yes.
Okay, yeah, I'm good.
Okay. Have you joined the presentation?
Yeah, is it the footprints with the hematology-oncologist on top?
Yes.
Okay, yeah, it's there.
Okay. Perfect. Okay. Please mute yourself again. Lori, have you got it? Lori, are you still with us? Lori? I think we lost her on the phone as well. Okay, I think we lost Lori, so I'm gonna start and she can catch this on the YouTube video. Okay, so welcome guys on the training. I just want to say something before I start. This training, I just want your mind be set in this way. This the knowledge you're gonna get through this training should enable you, give you a profound understanding of the environment you're working in. So as an example to show you what I mean by this, when you go to the Best Buy store and you ask the guy standing there, about the difference between the 4K screen and the normal screen, and he says, okay, the 4K screen is better, just like this. Or he gives you information, okay, this is kind of more pixels in the screen, this is gonna give you this kind of good contrast with colors, and it works perfect with wide screens or curved screens, and he starts give you some information. It's most likely than not you're gonna buy the bigger TV with the most up-to-date technology, and you pay more money and he makes more commission if he has this kind of information and he is able to convince you to have this high-end technology. But if he just said, okay, the 4K is better, it's more likely than not you're not going to pay the 4K unless you already know the 4K. So you get the idea. When you know what you're talking about, this is going to enable you to seem more confident, to start more conversation and to relate to what the doctor says, and have this kind of conversation with him that's most likely than not is going to enable you to build this relationship, or deepen this relationship, or to convince him, or to seem self-confident. So this is the first point of the knowledge you were going to go through this training. The second thing is what Dr. Sharif and Ahmed call situational awareness. So when you are asked something, or the doctor says something to you, you can think on your feet and answer the question, or because you are aware of the situation, what's happening, what's going on. So the information we're going to go through, it shouldn't be directly related to closing the deal you are working in right now, you are working on right now, but it's having this kind of information in the background of your mind is going to take you to the next level. Okay, so the first part of the training, which is the first 6 episodes, is going to be talking about what happens there. By there, I mean the hematology-oncology clinic. So the first episode is going to be talking about the hematologist-oncologist himself. So we're going to be talking about his work, his education, and his specialty, and his team, and stuff like that. So let's start. By the job description of the hematologist-oncologist. So the hematologist-oncologist doctor is a dual specialty. So he has 2 board certifications. Just to understand what does board certified mean, each doctor, before he's able to practice medicine, he has to be board certified. He goes to the exams for the board makes, and to make sure that the board knows that the knowledge and the experience that this doctor has enables him to go and treat patients. So there is a board for hematology and a medical board for oncology. And the hematologist-oncologist doctor take the exams of both boards. And he works with the hematology diseases, which is basically the diseases of the blood, either the WBCs, the white blood cells, or the red blood cells, or the platelets, or whatever. It just deals with the diseases of the blood. And the oncology, it deals with the tumors. Basically, by the new arrangements, the main healthcare provider for a patient with cancer is the medical oncologist. So if there is a patient who has cancer and goes to his primary care physician, and the primary care physician should send him to the medical oncologist, and then the medical oncologist decides if this tumor needs surgical intervention, so he's going to send him to a surgical oncologist to perform the operation, and then sends him back to the medical oncologist to continue the treatment. If the medical oncologist decides that the patient needs chemotherapy, he's going to give him the chemotherapy himself. If he decides that the patient needs radiotherapy, he's going to send him to the radiation oncologist and ask him to do this kind of thing, that kind of thing. So the main healthcare provider for a patient with cancer is the medical oncologist. Now, I want to give you a hint why there is dual specialty called hematologist-oncologist. I mean, there is a GI doctor, there's a surgeon, there's an orthopedic surgeon, there's why there's a dual specialty that shows hematology and oncology together. And to understand this, we have to have a quick look on the history. So this is basically what used to be before. There are two main approaches for the treatment of any disease. It's either surgery or not surgery, which used to be before drugs. So each disease can be treated either by surgery or by drugs. So when we started when the science started approaching the tumor diseases, the oncology, we didn't know either it's going to be surgery or drugs, which means surgery or medicine. But then most of the tumors were solid. So all over the body, the tumors are solid except for the blood. So basically, it goes to under the surgery. Hello? This is Nihal. Okay, Nihal, can you please put yourself on mute?
Oh, okay.
Okay. So those kind of tumors, because they are solid, they went directly under the surgery. So we started having this specialty called surgical oncologist, an oncology surgeon, because all the tumors were solid. But then we started to know some tumors that are liquid, which is the blood tumors. So back in the 1960s and 1950s, when we started, knowing about leukemia and lymphoma and the hematology tumors, the doctors who were treating those kind of tumors were the hematology doctors, because they treat all the hematology disorders, and those kind of tumors cannot be treated by surgery, so the doctors were working on them. But actually, they didn't have so much drugs or approaches to treat them. So leukemia was just a killing disease. So when somebody is diagnosed with leukemia, he starts preparing for his funeral. But then we discovered, or we invented, the chemotherapy. Chemotherapy was a revolutionary approach to treat tumors. So if somebody has tumor, he's going to go to the oncology surgeon who's going to perform surgery and then take chemotherapy. But the surgical oncologist has no idea about the chemotherapy. So there has become a need for somebody to get the knowledge of the medical care for solid tumor. And here becomes the medical oncologist. Both of them, because the medical oncologist work directly with chemotherapy and the hematology doctor work directly with the blood tumors, there is this intersection for the blood tumors, which is treated by chemotherapy. And this intersection has grown too much that the most of hematology doctors have been working on, blood tumors, and most of the chemotherapy doctors were working with blood tumors. And instead of getting board certified in hematology and spend 2 years to get this to be board certified, and getting board certified in medical oncology and spend 2 years doing that, they combined both training programs to develop a training program for 3 years and become board certified on both of them. That's why we have the hematologist-oncologist dual specialty. So now we go to the education of the hematologist-oncologist. So it starts with the undergraduate education. He goes to college. Most commonly, he goes to a science college, biology college, or something like that. He spends almost 4 years to get his bachelor degree. And then he goes to medical school to spend another 4 years. 2 of them is dealing with, the basic medical knowledge, anatomy, pathology, and stuff like that. And 2 years working with, doctors and diseases and patients directly in the hospital. And when he graduates from medical schools, he has to go to USMLE exams, which is the United States Medical License Examination. And those are tough exams. Like it takes you almost 2 years to study for those exams, even if you are graduated from a medical school, to finish those kind of exams. And when you finish those kind of exams and you get good scores, you now apply for the match process. And when you apply for the match, you are seeking training programs. And the matching process, it just matches your scores with the training programs you need. And this matching process is gonna decide which specialty you go to. And then when you get when this matching process finishes, you get the residency, which is your training program, and you spend 3 more years. Usually they would call the first year the residency years internship year, but this term is kind of outdated right now. So when you finish when you graduate from medical school, you go to the USMLE exams, study for them, get your scores, apply for the match, and then you get your residency. You spend 3 more years. Most commonly, the residency is dealing with a more general topic, like you get residency in internal medicine, you get residency in orthopedics, you get, it's just general topic. And when you finish that, you are now qualified to go to the fellowship program. And the fellowship program is going to give you the subspecialty. So hematology-oncology is a subspecialty of internal medicine. You become a resident of internal medicine. You spend 3 years, and then you apply for the board certification exams. You become board certified internist, and then you start applying for the fellowship. And when you apply for the fellowship, you are trying to seek a subspecialty. And you may choose hematology-oncology, and then you spend 3 more years of training in the field of hematology-oncology, and then you get to apply for the board certification exams, and you finish them, you're finally board certified. So when you are board certified, you have to continue your medical education. So each doctor has to spend some educational hours each year to renew his license or to maintain his license. Other than that, if he stops his education, his license is going to be suspended. And the whole idea of telling you about the education of the hematologist-oncologist is, I just want you guys know how much science and information is in the head of this guy. He spends almost 14 years doing, direct training and, and studying and training and studying and examinations and exams and exams and exams and exams just to be board certified. So the next time you're talking with a hematologist-oncologist, just imagine how much information in his mind, and how, when we are telling him, something basic, we don't know what's the BCR-ABL or something. He just, what we look in his mind, because we have no idea about what he's talking. Of course, you're not going to be doctors, but at least you have to have something to, to start the conversation or to talk with, to talk about with the doctor. Then we go to the lifestyle of the hematologist-oncologist. 72 of the oncologists spend like 30 to 55 hours per week seeing patients, with average 17 minutes for each patient. So what does this piece of information mean? When you are sitting with a doctor and you tell him, I'm going to finish with you within 5 minutes, you have to respect this, because usually you're going to take more than 5 minutes and more than 15 minutes. So you are taking the whole time of a patient. I mean, he could, if he's thinking about saving the lives of others, he could have saved the life of a patient in this time. Or if he's thinking about money, he could have made, maybe something around $400 in this 17 minutes. So just when you tell him that or her, I'm not going to take too much of your time, please respect this, because each 17 minutes mean a patient for him. And there is another thing interesting. The doctors spend like 12 hours per week working on paperwork and administration, and they really hate this, because they think they are overqualified to do the paperwork, and they usually get confused with the paperwork. They hate it. So you may relate to this next time you're talking to a hematologist-oncologist. In a report that measures the quality of life of doctors, the one dealing with the hematologist-oncologist was talking about the burnout. So the burnout is the loss of enthusiasm for work and feeling of cynicism, and a low sense of personal accomplishment. When the doctor hates himself, hates his job. And they were trying to track the causes why the doctors feel they are burned out. And the first thing was bureaucracy, because they hate the paperwork they're doing. And this is a very big issue for the hematologist-oncologist, by the way. And the second cause is they work for too many work hours. The third one is the computerization, and I'm not sure why that. Maybe because most of the hematologist-oncologists are, from an older age group, so computerization may be an issue for them, and they hate it. And the maintenance of certification requirements. So because they have to go to exams maybe every other year, and they have to submit papers, and they have to submit their continuing medical education, and they have to submit a lot of papers, a lot of stuff. I'm not sure exactly what this is, but I remember I was talking to a pathologist in a hospital sometime, and he was responsible for the maintenance of the certifications of the doctors, and he was talking about this as his biggest issue in life. Like, the guy is the pathologist, and he is, he's running the pathology lab for the entire hospital. But again, all of this is not a problem for him. His problem was to maintain the certification of the doctors working in the hospital. And when they surveyed how happy the hematologist-oncologists are, they found them to be the second least happy doctors in their lives outside the work. But they are just below average of happiness at work, which is kind of interesting for me, because those kind of doctors are working with, depressed patients, end-stage diseases, and they are the people who tell you the bad news. Nobody wants to be diagnosed with cancer, of course. But then, your hematologist-oncologist is the guy who's going to tell you that, okay, I'm sorry, you have leukemia, and we're going to start having chemotherapy every week or something. So, but this didn't make them like the least happy at their work. They were fine, but outside their work, they were the second least happy doctors. But they are really weird, because when they asked the hematologist-oncologist if they're gonna do all this all over again, they said yes. Most of the hematologist-oncologists would go to medical school. Most of them will take hematology-oncology as a subspecialty. Most of them will work in the same kind of practice they are working right now. And then when they asked them why would you do that? Because they felt the gratitude of their patients. Most of the doctors of the hematologist-oncologist, if you go through the reviews of the doctors online, or you talk to the doctors, or you talk to the nurses and ask them if the patients love their doctors or not, the most important thing they're going to tell you, because the patients feel grateful for the doctors, because the doctors spend a lot of time with them, try to educate them about their disease and take care of them and share them their personal issues and stuff like that. So they feel really grateful for their doctors, and they are really good at what they do. So just they have a high self-esteem. They know they are good. They know they are well educated. They know they have a lot of information, and they know they save the lives of patients. And the third thing is to help others. I mean, most of the hematologist-oncologists, if not all of them, they are really ready to make the world a better place. They believe in that. I mean, of course, the world is going to be a better place if you have a lot of money and you make a decent amount of money and you have a nice house and you have a nice car and you travel abroad. This is going to make the world a better place. But other than that, beside that, they are really making the world a better place for their patients. They are taking care of them. They are saving their lives. Just think about if a doctor who has a patient with AML, this person is gonna die within a month if the doctor doesn't interfere in his, with his disease and start treating him. So the idea is they are really ready to make the world a better place, and this makes them, even though they are not happy with their lifestyle, but if they were asked to do this all over again, they will certainly do. Now let's talk about the money, the compensations of the doctors. So this is a map that shows you the average compensation by geographical area, and I was really shocked by the doctors in California make the lowest in the country, and the doctors in the north central area make the highest in the country. So now you know this map, you know your territory, and you know how much your doctor is being compensated for the work he does. This may be a very good conversation starter if you don't know how to talk to your doctor, what to say, what not to say, and maybe it just tells you how happy your doctor is and how much he's making the world a better place for himself. And now this just tells you the average of compensation by practice setting. So as you see, the doctors who work in outpatient clinics, they make the most of the money. And when we're talking about the outpatient clinic, when you have a cancer center that's next to a hospital, and they have some inpatient patients who go to the hospital, and an outpatient clinic, which is usually when the doctor is able to send us specimens, those doctors are making the most, the highest compensation in the different practice settings. So you go through them, you'd realize that the outpatient clinic is the most fruitful for the doctors, and then the single specialty group practice. When you have this hematology oncology practice with 4 doctors, with 5 doctors, this makes money. And then the healthcare organization, when they have those kind of very big cancer centers that develop, the clinical trials and that develop the, the guidelines and stuff like that. And then the multi-specialty group practice, when you have, internal medicine group practice that has different subspecialties in the same practice. And then the hospital, and then the solo practice, when you have, this office that has only 1 doctor and the practice only hematology oncology. And this is the lowest, by the way. And then we go to, of course, we don't work with the academic or research or the military or the government. We don't work with them. So now when they ask the oncologist who feels fairly compensated, and you will realize that men are really greedy. They don't think they are fairly compensated at all, even though they are making this tons of money, but they still don't feel they are fairly compensated. And you have to keep this in mind when you are talking with your doctor. And this differentiate between the self-employed and the employed doctors. And this is really interesting because the employed doctors who work for hospitals, they make less money, but they feel more fairly compensated than the doctors who work for themselves. And they are making more money, but they're still not, don't think they are fairly compensated. Or at least this is the perception they have about themselves. Now they tried to measure, the assets and the income of the doctor. How much he feels he's making, and thinking about the future and stuff like that. So I'm just trying to give you an idea about what the doctor thinks about himself. Is he happy? Is he not happy? What makes him happy? What makes him not happy about the money he makes? Now, the last thing we have, I don't want to take more of your time. We are talking about the oncology team. And the oncology team starts with the oncologist. He can be either an MD or DO. So what's an MD and DO? Most of the doctors are going to be MD. And this is kind of thing that has a historic background when the medicine was like, you have a white coat, and you have some grass in your lab, and then you are a doctor. So there were two approaches of medicine. The one who gives you some drugs and some herbs and stuff like that, and the one who this was an old approach that thought that all the diseases come from the bone, and if you are giving moving the joints in a specific way, this is going to make you healthier and it's going to treat all the diseases you have. This is a very, very historic point of view. But for this, they developed the medical doctorate degree and the doctor of orthopedic medicine degree. So doctor of orthopedic medicine does not mean that this doctor is orthopedic, orthopediatric, or orthoped. I'm not sure how to pronounce the word, but he's not the doctor who's working with the bones and the bone fractures and stuff like that. No, this is just, there are some medical schools now, as for now, they take the same training, they take the same education, so they are fairly equal. But the DO makes like 10% lower money than the MD, and their schools are really cheaper than the MD schools and the training programs, but they are fairly equal in their education and their training. Nothing now to do with with the herbs or with the moving the joints and stuff like that. So just I want to give you an idea about the title of the doctor. Like when you see a doctor as DO, this might be an interesting conversation starter with him, and to ask him why would he choose to go to a DO school instead of MD school. So the team has the medical oncologist. He's the person who administers, who gives the chemotherapy, who writes the prescription, who decides the dose and the type of the chemotherapy and the period of treatment, and measures the progress and stuff like that. And then the surgical oncologist, he's the guy who's with a scalpel. He's the guy who's going to cut the tumor out of the body and then send him back to the medical oncologist. And then the radiation oncologist, who is a doctor specialized in deciding the doses and the ways of delivery of the radioactive drugs. But again, the main person who's responsible for the entire treatment plan is the medical oncologist. So this is the oncologist part, and then the nurse part. So we have 4 kinds of nurse, titles. The RN, which is the registered nurse. She is just a basic kind of nurse. She graduated from a nursing school, and she got certified. She got licensed to practice, and they are the most, the most percentage of nurses you're gonna find in the offices. And then the OCN, this is an oncology certified nurse. She goes to be, certified in oncology. AOCN, which is advanced oncology certified nurse. This means she has studied more. Maybe she has a master's degree. She has a lot of knowledge. So then this makes her more of a decision maker. And again, the AOCNP, which means the advanced oncology certified nurse practitioner. And this nurse practitioner is actually able to write prescriptions and order tests. So she's more like a doctor than a nurse, and most likely she's going to be, a decision maker in whatever office she has. I personally have an office that has a nurse practitioner, and she is a decision maker in her office. And then the rest of the team. So we have the oncologist, we have the nurse, and we have the rest of the team, the pathologist, the palliative care doctor, and nurse. Palliative care means the care that we give to the patient. It has nothing to do with treating his disease, just trying to make his life better. You know, if he has pain, we give him pain control. If, you know, the tumor just blocks his digestive tract, we give him, you know, a shunt or something. So it's just a way that we are trying to, you know, to make the patient die in peace instead of dying in pieces, you know. And then the oncology social worker, the rehabilitation therapist, and this is the oncology team. This is a quick review about the hematologist-oncologist. As soon as I finish with the webinar, I'm gonna send you handout. Just going over the handout, I want you guys have this idea. So the handout's more of a reading thing. You, yeah, you can now come back to the window of the webinar. You will see the hematologist-oncologist handout. Can you see it? If anybody have any kind of difficulty coming to see the PDF, just unmute yourself and speak. Okay, now I'd assume everybody is okay. So this is how's the everybody? Hello?
Yes, we can hear you.
Okay, please mute yourself, Ahmed. Okay, I still hear some noise, but it's okay. So this is how the handout's gonna look like. It's you're not gonna study the handout. It's just more of a reading type of thing. So you just go through it. It has some more information about the hematologist-oncologist. You can use it to review this information every once in a while. It just gives you a hint about the hematology-oncology, and it has all the stuff I have said. I haven't said anything that's not in the handout. Maybe when you read it, you have some questions. Just feel free to talk to me. So as soon as I finish with the webinar, I'm gonna send you the hematologist on the PDF in the mail. Yeah, if you have some time, you can review it right now. But if not, it's okay. You can review it, later. I think now I'm finished with the webinar, and I'll be more than happy to receive your feedback, to have your questions, or if you think this kind of information is going to be useful in any way, or you have an experience or a situation before that this kind of information would have helped you in, just please feel free to share with us.
Well, first of all, I really want to thank you, Karim. I think this is amazing. Like you were saying, this is just like a beginning, and it's kind of like the whole idea is to make us all aware of everything that happens in the office. Who are we dealing with? Learning about our customers, our clients, which is primarily the hematologist, oncologist. What's their background? What's their, what's going on in their heads and what they're thinking. So all of this, again, serving the situational awareness that we were talking about. I'm sure as we continue to build up information and going more deep into like more specific and more technical things, it's definitely going to help us get to that level. Just a couple of interesting things that I noticed. The slide basically that really caught most of my attention was the slide with the pain or the things that frustrates the hematologist-oncologist. And the main reason is because we are, as a salesperson, your objective should not be to just sell them. You should actually try to go into a relationship where it's beneficial for both of us. So you need to learn about their pains and what they're going through, what frustrates them, and see if there's any possible way to offer them solutions for that. One of the things is the continuing education and maintenance of certifications, and this basically takes us back to like medical or drug companies. Like that's why they offer all these webinars and all these like classes, in sort of like a classroom setup where they get to like be accredited towards maintaining their certificates. So that's something we can definitely look into. So please take a note of that, Nihal. And another thing that I noticed is the computerization part. Even though it's like, you know, the reason it caught my attention is because it's basically based on change, and this shows you how much people hate change, because there's no way every single one of those doctors knows that using computer for everything that they have or they do is definitely gonna serve them better, and it's gonna ease their life on the long run. However, they still hate to go through it because of the change. So that's just the few things that caught my attention. But I was actually very also curious to find out who is the first unhappy, you know, about their job. Like you said, the hematologists were the second one. I'm just curious who's the first. Kareem. Kareem, you're on mute. I don't know if you can hear me.
Okay, I just don't remember it now. I'm gonna find it for you in the next couple of seconds. The critical care doctors.
Critical care. Well, it makes sense because they, of course, they have to like work crazy hours, and they sometimes have to like work overnight, and they're always on call. And by the way, that's also why they usually like they work a week and they take a week off, something like that, which makes sense. Now, another thing that I noticed is that even though they are unhappy, the main reason, and look at this, the main reason they still want to do it, and if they go back in time, they will still do it, is basically because of the patient. Like they feel two things. They feel like they're helping the patient, and then they feel appreciated by the patient. So it shows you that, again, it has nothing to do with logic. It's all emotions. So when it comes to like making decisions or feeling good about yourself, or like being happy or not happy about what you're doing, it's all ties back to like emotional reasonings behind it. There's no logical reasoning behind it, because obviously, you know, if you take it by logic, if you think about it, there's no way they're going to say that. And that's why it's very important for us to emphasize about the difference that we bring to their patients, with things like being able to, you know, turn over the report, for example, in such a short time, and having this personal relationship and personal care with the doctors and their patients, and, you know, with their billing, for example, and everything that they go through. So these are the important parts that we need to stress out to them. So, but overall, I'm very glad that you know, this was a very good start, Kareem. I don't know if anybody wants to share anything, but or they have a comment. Anybody, you know, it's very important to like have like conversations going on so that we can share experiences.
Hey, I just want to say great job, Kareem, Ahmed. Presentation was very informative. You guys did a great job on this first presentation.
Thank you.
Anybody else? I guess it reminds me of this situation, Kareem, you had with the doctor in I don't even remember where they were. The one that used to work in Alaska, and, you know, they had no time. Oh, that was in Wyoming, I think, and, you know, they had no time to speak to you or whatever. And then when you said, you know, I can't help but, you know, notice and appreciate all the efforts that you do with the patients in Alaska, and that's when he stopped and talked for hours. I know you have a meeting with them this week, so. But the point here is that once you communicated at that level, showed them that you care and you saw the difference that they're trying to make and you appreciate it, that's when you like have conversations, and like you're able to change the situation from them not being accepting to talk even for a couple of minutes, and to like stopping. And even though an hour you probably cost them, based on what you said, you cost them maybe like a couple of $1,000s to have that conversation with you. So, but they still did it happily. So.
Yes. Yes, that's happened for me.
Anybody wants to share anything, guys? Let's, because it's 10 a.m. already.
Mm-hmm.
Any feedback? Any questions? Kareem, are you going to be sending us another test?
Yeah, I am gonna be sending you the same test, So now, as you have the knowledge, you're gonna respond to the same questions in a different way.
Okay. Anybody? Nuran?
I love this. This was really good. I love the slides. I love the weirdo part under the I love my job thing. I think that was awesome. Great job, Kareem. That was great. I love it. I can't wait for the next one.
Thank you very much.
All right. I think you got us all excited, Kareem. Good job. So.
Thank you very much. I think I'd propose something. So if you know that the bureaucratic issues and paperwork is the thing that the hematologist-oncologist hates the most, then when you are showing him our report, you're going to say, okay, you don't have to do so much paperwork with it. You don't have to read all through it. We're trying to, you would uncover the pain of the doctor having this kind of papers and paperwork and reading through the papers and all those kind of stuff. So you just uncover this pain and remark that you know that this is an exhausting issue for him. You just say, okay, we are trying to make this as convenient and as easy for you. We don't want you go through a lot of papers. We don't want you have a lot of paperwork. I know that you hate this and I know that you hate that. I think adding this to the report part of our sales page is gonna, maybe get a link with the doctor.
Right. I actually have a question, Kareem. What do they usually do? I have it written down here, but I forgot to ask it. So what do they do in this paperwork that takes, you said, about 12 and a half hours a week? What do they do? Like what does it take them to do the paperwork?
So for the sake of getting reimbursed of what they've done, they have to kind of log everything they have done with the patient, the same way we do with our calls. When we log our calls on Salesforce, they have to do the same way. So they have to log everything they've done with the patient, and this is a lot of paperwork.
But usually they have like they just record it, and then they have someone that does that for them.
I don't think so. They have to write it themselves. Other than that, they're not going to be reimbursed by the insurance. This is as far as I don't have too much experience in the clinic. Maybe they find a loop back behind this, but the thing I have read about and I have seen it myself, they have to write everything by themselves.
Yeah, but they have transcription. That's why they have transcription. Like they usually, most of them, I'm sure some of them still do it the manual.
Hello? Hello?
Oh, they just speak it out loud, record it, and then they have people, scribes and transcriptions, that they sit down and put everything on paper.
I don't. Maybe this happens. I don't know about this, but I've seen personally my doctor. He
used to
a lot of
be
time in the visit to record and log everything about my case in his system, the EMR system and stuff like that.
interesting stuff.
Like if I spend like half an hour with him, he talked to me for like 5 minutes and spent 25 minutes on his computer.
Okay. Any other questions, guys, or anything?
I mean, if there's anybody has anything to share.
Well, Kareem, hey, it's Jean.
Jean has to close the
I was
speaker.
going to agree with Kareem that I think the administration, even though we're using computers now, has gotten worse because of the EMR. And my doctor does the same thing. He has a laptop, and he orders his scripts for the laptop where he used to scribble in. He does everything.
Hello, guys, can you hear Jane?
Yes, but tell her to put you on mute. Like close the turn
Yeah,
off the.
I'm gonna put myself on mute.
Not you, her. Okay, that's the same way. No, but you can't put yourself on mute. Now we can't hear her. She has to close the speaker.
I will stop talking anyway.
Okay. You can go on, Jean.
I don't really have anything more to add. I just was agreeing with you.
Okay.
And I think the doctors are spending more and more time on the computers entering the information. I think a lot of that is driven from the EMR.
Thank you. Okay, guys, it's 10:04 already. I'm glad we could all make it to the first episode of the training. I'm glad you are all excited, and after, like, before we finish, you have to take the test again. It should take like 2 to 3 minutes of your time, just to make sure that you have the information in your mind. As soon as we close the webinar, I'm going to be sending the handout. Just please find the time to go through it, and review it every once in a while, just to keep yourself, having this kind of information. Thank you, guys. Is there anybody who wants to say anything? Okay, I'd say goodbye and have a nice week.